I am Dr. Jigisha C. Pujara, Professor in Cardiac Anesthesia, UN Mehta Institute of Cardiology and Research Center, Ahmedabad. Welcome all of you for a T series for congenital heart disease. Herewith I am presenting transesophageal echocardiography for ventricular septal defect. The term ventricular septal defect VSD denotes a gap or opening in the ventricular septum, most common form of the congenital heart disease, comprising 35% of the CHD, and smaller the VSD may undergo spontaneous closure. Larger VSD required to address either surgically or the device closure. Several anatomical distinct types of the VSD morphologically, by location, by shape, by size. Transesophageal echocardiography is a valuable imaging tool for diagnosing and managing ventricular septal defect. It offers detailed view of septal anatomy, shunt flow, and associated anomalies. TEE also provide essential information and guidance during device closure of certain type of the VSDs, either in cardiac catheterization laboratory or via perventricular approach or in the surgical field. Here points of discussion will be preoperative assessment of VSD anatomy, morphological classification of the VSD, intraoperative guidance during the repair, post-operative evaluation for residual shunt, monitoring cardiac function and associated anomalies, TEE in the cardiac catheterization laboratory. Anatomy of the ventricular septum. Interventricular septum divided into muscular septum, membranous septum. Membranous septum is small and located below the aortic valve, adjacent to the septal leaflet of the tricuspid valve on right side, and forms the superior border of the alveoli on the left. A remainder of the septum is a muscular septum. It fans out in inferior, apical and anterior direction. Muscular portion divided into three areas. Inlet septum, posterior, situated between the atrioventricular valves, and trabecular septum, mid region, extending from membranous septum towards the apex. Outlet or the infundibular septum, which is anterior below the great arteries and straddle the crista supraventricularis. VSD not always straightforward, vary in location, shape and size, and given the curved three-dimensional nature of the septum, not all of the VSD are optimally visualized with the single TEE view. Through the thorough systemic evaluation using the combination of the different TEE views with the multiplane angle are necessary. Coming to the perimembranous VSD, membranous portion of the septum is so small, VSDs involving this area usually extend somewhat into the adjacent muscular region, termed as the perimembranous VSD. So, membranous VSD usually termed as a perimembranous VSD, and it's also called as a conoventricular VSD, infracrystal or the paramembranous VSD. It accounts for 80% of the congenital VSDs. It can associate with the septum aneurysm and may involve septal leaflet of the tricuspid valve or may be associated with the aortic regurgitation. Another is the muscular VSD. Next common are trabecular or the muscular type of the VSD, vary in size, location and number. They are divided into mid, anterior, apical and posterior. Both posterior muscular and inlet VSD located close to the posterior border of the ventricular septum, but posterior muscular VSD situated more inferiorly, while the inlet VSD is more superiorly. Another entity is which is septum. When there are numerous separate muscular VSDs of varying size are there on the muscular septum, it is appear like the Swiss cheese, so it's called as a Swiss cheese septum. Inlet and outlet VSD is less common defect in the inlet or outlet septum. Inlet type rare in the isolation and are usually associated with the endocardial cushion defect. Outlet type defects may occur above or below the supraventricularis. Those above may abut the semilunar valves and are also referred as the supracrystal or the doubly committed supracrystal VSD, subarterial defect. These are often associated with the aortic valve prolapse or the aortic valve regurgitation. Here you can see various types of the VSD. Number one is membranous VSD, two is outlet VSD, infracrystal. There is crystal portion above the two, and above that is the supracrystal. You can see in this image aorta and the pulmonary artery. Here also you can see the inlet VSD at the 4 position, and trabecular VSD, the large portion is a 5 is a trabecular VSD. Same here in the other figure, various VSDs can be visualized. Conoventricular VSD, first figure, conal septal malalignment in the second, conal downward first is the conal septal hypoplasia, and middle one is the AV canal type, and last one is the muscular VSD at various position as described. Morphological classification, inlet or the AV canal type, portion of the septum adjacent to the atrioventricular valve by the crux of the heart. Outlet or the conal or the infundibular septum, muscles that sits between the two great arteries and separate the outflow tract. Malaligned VSD, malalignment of the displacement of the conus or the conal septum from the remainder of the plane of the muscular trabecular septum. These VSDs are called malaligned VSD, and if anterior malalignment of the septum is in case of the TOF or some DORV, resulting into narrowing of the RVOT and or the hypoplasia of the pulmonary valve and aorta overriding the remaining plane of the interventricular septum, and aortic valve forms the roof of the VSD. When there is a posterior malalignment of the conal septum, it results into the narrowing of the LVOT in hypoplasia of the aortic valve. This type of defect has a high association of the aortic arch obstruction, including the coarctation of the aorta or the interruption of the aorta. So displacement, here this figure shows the displacement of the conal septum. In first is a normal, second one there is a tetralogy of Fallot, and there is a displacement of the conal septum anteriorly, and so the last figure shows the displacement of the conal septum posteriorly. Anterior displacement causes the hypoplastic RV and pulmonary valve, and in the case of the anterior posterior displacement, there is an interrupted of the aortic arch. Two additional considerations regarding the VSD. First one is there are combination of the different types of the VSD, large perimembranous VSD coexisting with one or more of the muscular VSDs, and another second one is despite the specific location of each type of the VSD, in some instances a large enough defect will extend and overlap into the various regions, like large perimembranous VSD extending into the inlet septum. Sometimes it also extends into the outlet septum. Key T views for the VSD assessment are mid-esophageal 4-chamber view, mid-esophageal long axis view, mid-esophageal RV inflow-outflow view, transgastric short axis view, deep transgastric views. These views allow optimal visualization of the septum and blood flow pattern. Coming to the mid-esophageal 4-chamber view at 0 degree, standard transverse plane at mid-esophageal 4-chamber view, crux of the heart, the inlet septum, and most of the muscular septum seen from AV valve down to the apex. So it is very important mid-esophageal 0 degree 4-chamber view. By withdrawing the probe from that position and doing the flexing the probe anteriorly, so anti-flexing of the probe from the crux, one can pass through the perimembranous VSD region, and you can adjacent to the tricuspid valve when LVOT in view. Here perimembranous defect can be seen in 2D imaging, and any involvement of the tricuspid valve aneurysmal tissue can be detected. Color flow Doppler demonstrates shunting through the perimembranous VSD. This is usually a favorable angle for the interrogation of the spectral Doppler, pulse wave as well as the continuous wave Doppler. Any left ventricular to right ventricular shunting can also be adequately seen. Multiplane angle at 0 degree, which is known as the Gerbote defect. Here you can see the mid-esophageal four-chamber view at 0 degree, perimembranous VSD nicely visualized, and tricuspid aneurysmal tissue. So you have to do the color Doppler as well. Compare with this, many times VSD is large enough but covered by some tricuspid tissue in the case of the perimembranous VSD, but color flow showing the large defect. Any prolapse of the tissue into the LVOT or subaortic obstruction like a discrete membrane or ridge can also be visualized in this same view. Size of the defect in the septum as noted by imaging and effective orifice by color Doppler can be different if aneurysmal tricuspid valve tissue causes the partial obstruction of the defect. If endiflexion continued with a slight withdrawal of the probe, one can get mid-esophageal RV inflow-outflow view. Multiplane angle here will be 60 to 90 degree. Somewhere around the 70 degree you can get the inflow-outflow view. This view is comparable to inverted transthoracic parasternal short axis view and image perimembranous VSD as well as outlet septal also. Outlet septal is supracrystal defect quite nicely can be seen here in this view. This image showing mid-esophageal RV inflow-outflow view with the aneurysmal tricuspid tissue. Here asterisk shows the perimembranous VSD and you can nicely see the color flow. Muscular VSD mid-esophageal four-chamber view, multiplane angle at again 0 degree for inlet, and the muscular VSD is retroflexion of the probe. For mid and anterior muscular VSD, one should do the antiflexion. Imaging used in the conjunction with the color flow Doppler to visualize smaller defect. When there are smaller defect, multiple defect, or along with the smaller defect, larger defect, one can base easily the smaller defect. So color Doppler here will be benefited. Maintain adequate size color flow Doppler sector, particularly for the apical VSDs, which are generally farther from the TEE probe. Here you can see the muscular VSD from mid-esophageal four-chamber view. Figure A showing the image of the inlet VSD. Here you can see in the asterisk and the level of the crux of the heart, and figure B shows the large inlet and apical VSD. There are two asterisks. Above is the inlet VSD and downward is the apical VSD. And figure C is showing the right ventricular hypoplasia with small posterior muscular VSD. Here again asterisk shows and RV hypoplasia you can nicely appreciate in this view. Transgastric views. Mid-posterior is very important. Mid-posterior inferior and apical VSDs are well visualized by advancing the probe into the stomach. One can get the transgastric position and while maintaining the probe antiflexion to achieve transgastric basal short axis view and mid short axis view. Further advancement of the probe will get the mid transgastric short axis view. Mid-esophageal long axis view, another important view for the visualization of the outlet VSD, transducer oriented in a long axis plane, multiplane angle 100 to 130 degree, and excellent visualization of the LVOT with the slight rightward counterclockwise rotation. RVOT can be visualized and more anterior superior VSDs as well as the defect in the outlet septum can be well visualized in this view. Mid-esophageal long axis view with the mid-esophageal RV inflow-outflow view provide excellent visualization of the LV and RV outflow tract obstruction. In case of the RVOT, subpulmonary obstruction due to the superiorly displaced moderator band and or the anomalous muscle bundle known as the double chamber RV, that is DCRV, become much more visible in this view. DCRV carries a well-known association with the perimembranous VSD. So, importance of the when there is a perimembranous VSD, it is very important to look after for the muscle bundle. DCRV one should address during the surgery. Otherwise, the patient can have the RVOT obstruction and gradient across the RV outflow. This image showing the DCRV from the deep transgastric view. This view is inverted view for the T to make it similar to the transthoracic. Here you can see in the A, at 0 degree you can see the DCRV, right ventricular, there is a muscle bundle in center, and you can see on in the B view there shows the turbulent color flow of the VSD in the muscle. There is a turbulent flow from the muscle bundle. Another is the supracrystal VSD, more anterior and superior location of the defect. Various views used for looking after the supracrystal VSD are mid-esophageal 0 degree with the probe anteflexion, and a mid-esophageal right ventricular inflow-outflow view is helpful to distinguish the perimembranous from the supracrystal defect. Perimembranous defect are seen between the 7 and the 10 o'clock position, while this supracrystal defect can be seen in a 3 o'clock to 6 o'clock position. This view is inflow-outflow view, and withdrawal of the probe slightly with the anteflexion will very helpful to distinguish the this supracrystal and perimembranous VSD. Sometimes perimembranous VSD having the outlet extension. So you can see here in both the position 3 o'clock to 7 o'clock, 3 o'clock to 6 o'clock and 7 o'clock to 10 o'clock position. There are two different flows of the color jet in this view. So this suggests the surgeon should look for when it is perimembranous VSD, but surgeon should look for the outlet extension of the perimembranous VSD as well. Supracrystal VSD, mid-esophageal 0 and 90 degree view. Here you can see in first image there is a VSD flow in the 0 degree angle, and second is outlet. This is outlet VSD and supracrystal VSD. In another B view, B image, it is a long axis view at around 90 to 100 degree angle. You can see the outlet VSD, supracrystal VSD, and you can do the color flow and the spectral interrogation of the VSD in this view. With mid-esophageal right ventricular inflow-outflow view with neo-sagittal plane with the multiplane angle between the 80 to 90 degree, the deficient conal septum become the readily apparent along with the location of the VSD directly adjacent to the both semilunar valves. Semilunar valves can also be seen in fibrous continuity with each other. If aortic cusp prolapse into the defect, here you can see through the defect protruding cusp is readily seen by both imaging and the color flow Doppler. During the evaluation of these VSDs, the LVOT and the aortic valve to be evaluated for any possible aortic valve disruption or any aortic valve insufficiency, because many a time the valve is distorted due to the VSD and the flow of the blood, higher flow of the blood, and sometimes this stretching of the cusp can cause the aortic valve regurgitation. So somebody should look for that also. Mid-esophageal RV inflow-outflow view, good angle of the spectral Doppler quantification of the VSD jet by the continuous wave investigation Doppler. Mid-esophageal long axis view, multiplane angle 100 to 130 degree, excellent for the assessing malalignment of the VSDs. Depend on the position of the conal septum, anteriorly or posteriorly malaligned. Posterior malalignment, protrusion of the conal septum result in the protrusion of conal septum into the LVOT, causing the subaortic narrowing and obstruction. It often associated with the aortic arch hypoplasia, coarctation of the aorta, or the interruption of the aortic arch. LVOT obstruction may not fully recognize since some blood flow. Here is a trick. When there is a large VSD near the outlet, LVOT obstruction, if there, may not be sometimes fully recognized since some blood can flow left to right through the VSD into the low resistance pulmonary system, and this significant gradient might not be seen across the LVOT by the Doppler assessment simply. So here what you should do is, in such cases, evaluation of the LVOT and aortic wall with the linear measurement of the aortic wall annulus and LVOT measurement plays an important role to diagnose for the LVOT obstruction. Anterior malalignment results in aorta that overrides the VSD corner septum protruding into the RVOT, causing the subpulmonary and the pulmonary wall narrowing like in the tetralogy of the Fallot. Here figure shows a modified mid-esophageal short axis and long axis view in a patient with the top. First image you can see at 0 degree, you can see the outlet VSD with the asterisk, and another view is a long axis view around 120 to 1 degree multiplying angle, and you can see the VSD at the outlet position is a claw cut off with overriding of the aorta. Here also you can do the spectral interrogation of the color flow here in this view. Another is the deep transgastric view with probe in anteflexion position after basal and mid transgastric view. Further advancement of the probe provide deep transgastric view with multiplane angle 0 to 10 degree, and the deep transgastric view long axis view produces image comparable to the subcostal coronal plane view. Crux of the heart and inlet septum, most of the muscular septum including the lower muscular and apical septum can be visualized. So transgastric view is beautiful view, deep transgastric view is beautiful view. You can see almost all types of the VSD in this view, and it is a subcostal view coronal plane of the transthoracic view. It is comparable with these. So you can see most of the views. If you cannot see in previous views, then this view is very much helpful to visualize almost all type of the VSD. With further advancement and anteflexion of the probe, more posterior planes in LVOT and membranous septum also visualized in this view. Perimembranous VSD can seen from coronal section, deep transgastric view, long axis view, and deep transgastric sagittal plane view at 80 to 110 degree. Here you can see the transgastric mid-papillary view, mid-muscular VSD with the asterisk can be seen here. Deep transgastric view are not always available as in case of the, even so remember in congenital heart disease is not only the one portion is a problem. So there are some other associated anomalies, and sometimes the deep transgastric view cannot be seen as in case of the dextrocardia, where stomach and heart are not in the same side of the body. This view might be difficult or not possible to obtain, so one should not waste the time once you know the this type of the anomalies along with the VSD. So dextrocardia, you may not visualize deep transgastric view. Deep transgastric view for perimembranous VSD, again this image is inverted, and you can nicely see long axis deep transgastric view. Perimembranous VSD is seen as a asterisk is an arrow, and here in this view one can get the aortic wall in the blood flow alignment with the color Doppler spectral, and Doppler assessment can be very well done of the aortic wall, very well done in this view. When evaluating VSD by TEE, color flow Doppler is an essential component of examination. Small VSD become apparent with the color flow. Magnitude and direction of the shunt can be assessed. Defect in the ventricular septum might not always shunt from left to right, as in the everybody knows tetralogy of Fallot, there is right to left shunt. In presence of the large defect, additional smaller muscular defect not readily seen, since the both ventricular pressures are similar, LVRV pressure similar, and the majority of the blood flow through the larger defects, so smaller VSD sometimes easily missed. One can use the color flow. So and reducing the Nyquist limit, smaller VSD can be seen flowing the blood by color Doppler assessment. To aid in the detection of the defect, color flow Doppler Nyquist limit can be, as I said, decreased to identify lower velocity shunt. In some cases, smaller defect might not be detected until the post-operative evaluation after the larger defect is closed. Now, larger pressure difference occur after operation. Larger defect is closed between the two chambers. So smaller defects become more readily apparent, and one can see the defect by Doppler dropout and the color flow also post closure of the larger defect. Intraoperative evaluation of the VSD, pre-operative assessment. TEE performed after the induction of the anesthesia and prior to the surgery to confirm anatomical findings, whatever in the 2D echocardiography. It include the complete assessment of the number, size, morphology of VSD using 2D imaging, as well as the color flow and the spectral Doppler to assess the associated lesions, obstruction of the outflow tract, semilunar valve involvement, or any other pathology. One should thoroughly do the all the view assessment, so not to miss out some valvular regurgitation, mitral or tricuspid, or some aortic valve regurgitation or obstruction, or RVOT obstruction by the muscle bundle. Moderator band is prominent, and there is a divided RV chamber into the DCRV. So one should go do the thorough investigation. How the defect is related to the outflow tract and semilunar valves can be visualized. The rootability of the VSD in some VSDs like DORV or some difficult TGA VSDs, many a time it happens. Rootability of the septum to the aorta is not possible, and decision can be changed rather than doing the complete repair. Sometimes one should go with the palliative repair, and may not be corrected completely. So relationship of the AV valve to the defect, if there is a straddling or overriding of the one of the AV valve over the VSD, sometimes surgical closure of the defect might not be feasible. So one should be experienced enough to see all these criteria. Post-operative assessment, VSD patch, residual defect, additional defect, everything should be checked properly. Ventricular function and valve function should also be checked. AV valve functions, particularly if AV valve function when there is a manipulation of the atrioventricular valve tissue during the surgery. Sometimes for the closure of the VSD, surgeon evolves the tricuspid valve septal defect and reinsert. During that, sometimes either tricuspid stenosis or the tricuspid regurgitation can occur. So one should see or check all these things, not only focusing on the patch and the VSD closure, but see other things. Semilunar valve function, particularly aortic valve, for any leaflet prolapse or regurgitation, even if it was not demonstrated in the pre-operative echo or not documented, and normal documentation. Also post-operative, sometimes you can find the regurgitation or some prolapse of the aortic tissue valve. New AR, especially eccentric, should raise the possibility of the leaflet entrapment or the perforation sometimes occur in the one of the cusp of the aortic valve if VSD was in the vicinity of the outlet or the membranous septum. Residual VSD less than 3 mm, many times you may not require to address, but VSD 4 mm or more than 4 mm usually required the reoperation. You have to go back on bypass and correct, close this VSD, otherwise it can give trouble. Patient is in failure, may not come out from the ICU, and prolonged ventilation and failure chances are very high, and in future vegetation also very high. So one should be very careful to look for the residual defect. One should also check RVOT muscle bundle in the mid-esophageal RV inflow view. Sometimes there is usually miss when perimembranous VSD, prominent muscle RVOT muscle bundle is not seen, and there may not be much turbulent color flow in this situation, and one can easily miss preoperatively. So preoperative and postoperative evaluation of RVOT muscle bundle in mid-esophageal RV inflow outflow view is mandatory. Location of the residual VSD can also play a role. Here in the image shows a residual defect close to the valve. A high velocity jet can potentially damage the valve, so one should address. You can see asterisk arrow and residual VSD. This may be very small, one should address, because high velocity flow will damage the valve and can be for the vegetation also can occur in future. And nowadays there is a role of the 3D for the anterior muscular VSDs. Here image showing the anterior muscular VSD three-dimensional view. Another view for the 3D moderate size of the perimembranous VSD. 3D view of the moderate size perimembranous ventricular septal defect adjacent to the septal leaflet of the tricuspid valve. Here you can see the VSD near to the tricuspid valve. Partially covered by the septal leaflet. Consideration was made to closing the VSD by a device in the cardiac catheterization laboratory, but the size of the defect and its morphology and proximity to the aortic valve, as seen in the 2D and 3D TEE, ultimately made a surgical closure preferable. So this 3D will helpful in deciding whether patient is fit for device closure or surgical closure, and any residual VSD during the surgery also can be well visualized, and exact location of the VSD regarding to the other structure also can be seen very nicely with the 3D. So nowadays 3D is emerging as a very useful tool for the VSD closure in congenital heart disease. Role of TEE in the cardiac catheterization lab. Muscular VSD, perimembranous VSD can be closed by device closure in the cath lab. Primary role of the TEE to assist the interventional cardiologist in placing the catheter appropriately across the VSD to device deployment and then positioning of the device. So right from catheter insertion passes from the VSD accurately, and device deployment, and once device in the position, the device position is proper or not, it can also be very well guided by the TEE, and particularly 3D will help more in this scenario. More recently, 3D TEE had shown considerable promise here. Recently, a hybrid catheterization and surgical approach had gained very much interest for both muscular and perimembranous VSDs, known as perventricular device closure of the VSD. Here in this technique, limited sternotomy done, placement of the guide wire and delivery sheet directly through the RV free wall and then across the VSD. T will guide the position of this guide wire across the VSD, and VSD device delivered via the seat through the defect. Then deployed T will monitoring is mandatory for continuous monitoring and the guidance. So exact placement of the device is guided by the T only. Here you can see the video of the VSD showing perimembranous VSD. You can nicely see the at 0 degree and at long axis, and interrogation of the spectral Doppler also possible. And another view here is another video is you can see the this VSD along with outlet VSD along with the vegetation. You can appreciate vegetation in this view, small vegetation at the aortic cusp, and severe aortic regurgitation with outlet VSD. So this is supracrystal VSD. Take home message: VSD should be evaluated from more than one plane. Remember that every heart is different, and as often seen in the CHDs, heart might not occupy its usual position. So, multiplane angle mentioned in book are not absolute and might need to be adjusted to obtain an optimal visualization of the VSDs. So if you cannot get the VSD properly in the as mentioned in the book, you should do the angle changer 10-20 degree more, or antiflex, retroflex, and right left position, because sometimes situs ambiguous, mesocardia, this type of the situation difficult to evaluate all the views as standard mentioned in the book. So one should expertise there in these also, and some patients have better sagittal view at 80 degree or 100 degree rather than the 90 degree, and each patient must be assessed individually. Thank you very much.